Hello, and thank you for checking out FirstcallID, How to Do an Infectious Diseases Consultation in Patients with Diabetes-Related Foot Infections. I'm Paul Bunce, an infectious diseases physician. In this session, we'll spend the next 10 minutes or so reviewing the key aspects of an ID consultation in a patient with a foot or lower extremity infection in the setting of diabetes. If you haven't done so already, I'd recommend watching our first session on how to do an infectious diseases consultation, where we cover the general principles of ID consults, whereas this talk really focuses on diabetes-related foot infections. As always, this content is for educational purposes only. Please consult current guidelines and use clinical judgment in your own practice. And before we dive in, just a few background points. First, the term DFI itself. Traditionally, it referred to diabetic and foot infections, but we've tried to get away from labeling patients and people by their comorbidities. So for a while, I was using the term foot infections in people with diabetes mellitus, but it was getting a bit hard to say, and I was running out of space on my slides. More recently, I've learned you can actually use the term DFI to represent diabetes-related foot infections. Second, teaching about diabetes-related foot infections can be challenging. There's a lot of variability in terms of the presentation, the microbiology, and the clinical course. And honestly, not all patients with ulcers have infections. Local practices also vary, so I can't give you a one-size-fits-all empiric regimen. What I do want to do is highlight the key principles that you can use and adapt. You can also tailor the antibiotics to the patients that you're seeing, and ideally we'll be tailoring our antibiotics anyways to the culture results. So the key points of our assessment. The first is assessing the clinical stability of the patient. Is this a life-threatening infection or a limb-threatening infection? Want to get a better history of their diabetes and its course over the years. If they've had any prior diabetic or diabetes-related foot infections, how they've been managed and how they turned out. We'll want to understand the details of the current infection and its course and its management to date. We'll include a general examination, but a focused wound assessment, and also assessment of vascular supply or arterial supply to the affected limb. Investigations generally include blood work, microbiology, and imaging specific to the conditions that we're trying to evaluate for or rule out. And from all of this, we'll provide our recommendations based on our impression. We'll want to characterize the infection, provide some management suggestions, at least initially, and potentially some ideas on prognostication. So again, the first step is to assess the stability of the patient. Is this a life-threatening or a limb-threatening infection? Is the patient septic, and will they require escalation of their level of care and monitoring, or maybe an ICU setting? Is this a limb-threatening infection where we're going to need to call a surgeon right away for surgical management of the infection? And in these patients also, if they're clinically unstable, they're the ones that we're going to start on empiric therapy as soon as we get the most basic investigations and cultures obtained. Whereas in more stable patients, we have time to work through the case and maybe get some more microbiological data to guide our therapy. In addition to our general past medical history, we want the more of the details related to their diabetes. So what is the type of diabetes and how is it managed? What is their current regimen? Are they using insulin? What's their most recent hemoglobin A1C? Do they have a history of micro or macrovascular complications? And if they have a prior history of diabetes-related foot infections, how severe were they? How was it managed? And how did things turn out? Next, we'll want to clarify the acuity of the infection. Has this been something that's been present for days, weeks, or months? And when was someone worried about infection, either the patient or those providing care? Was there some sort of inciting event or precipitant that led to the ulcer or signs of infection? And we'll gather any exposure history, if it's relevant, that may alter the colonizing flora to the wound. In terms of the management, had they received any antibiotics to date, and what was their response to therapy? Patients who have had multiple courses of antibiotics are more likely to develop colonization with drug-resistant pathogens that we need to take into account with our empiric therapy. And in terms of response to therapy, if a patient has taken an antibiotic and shown initial improvement but then relapsed, that suggests the empiric therapy probably was appropriate in terms of its spectrum, and we need to think about a deeper component to the infection, such as an abscess or underlying or contiguous osteomyelitis. In addition to our general examination, where we'll also pay attention to stigmata of infective endocarditis, as with all patients, we'll examine the affected limb, focusing on evidence of the inflammatory pentad, so rubor, calar, tumor, dolor, and loss of function. We'll not just look at the affected area, we'll palpate for any presence of fluctuants and see if we can express pus. We'll examine for any visible or exposed bone. And if there's a neuropathic ulcer or an ulcer where there's decreased sensation, we might want to attempt a probe to bone test where you take a sterile, usually a sterile piece of wood, you probe into the wound, and you can feel the gritty sort of sensation of the probe on bone that suggests contiguous osteomyelitis with high specificity. In addition, we'll always assess the vascular supply as well, specifically the arterial supply. Now, the Wi-Fi score, which stands for wound, ischemia, and foot infection, is used by many clinicians who manage diabetes-related foot infections. The components include an assessment of the wound, the degree of ischemia, and any local signs or systemic signs of infection. And these are combined into a score that can correlate with the risk of complications such as amputation. I'll say that there's variability in terms of how often this system is employed. It might be used routinely where you work, or maybe no one's even heard of it. Regardless, it provides a helpful framework for categorizing the three main components of ulcers in patients with potential diabetes-related foot infections. The investigations that we'll either review or request include routine blood work, including inflammatory markers. And as I say this, I'm not actually sure of the exact role for measuring and following inflammatory markers like the C-reactive protein. I've often said that they're only helpful if they agree with what you're already thinking, but they might be of value when you're evaluating early response to therapy or lack thereof, or after a period of time, if you're concerned about relapse, might be able to get some benefit from measuring them as well. From a microbiology perspective, we'll usually obtain blood cultures of patients unwell. You can attempt to culture the wound, but you have to be cautious. When you do a superficial swab of the wound, you're basically obtaining a culture of all the things that live on the surface, and you'll often miss what is lying deep to the surface and actually might be causing the infection itself. In some settings, we'll be able to obtain deep tissue or even bone biopsies for cultures, either by surgical methods or through interventional radiology. If those are available, especially if there's a stable patient, those are definitely preferred. I think it really depends on where you're working and the culture of the practice, what will be done in your patient's case. And then we'll follow up usually with imaging to assess for complications of infections. Now, a few additional words on imaging, where the main purpose is to diagnose or detect deeper infections such as an abscess, osteomyelitis, septic arthritis, or tendinosynovitis. Now, there's a few considerations as to which test to order in a given case, and it really is case specific. Most of the time, we'll start with an X-ray of the affected area. It's first line, it's cheap and quick to get. You can detect gas, and sometimes you can detect bony changes, evidence of osteomyelitis, and any misalignment or fractures, recognizing it has a limited sensitivity, especially early in an osteomyelitis. MRI is the best test for characterizing soft tissue and bone or joint involvement, but it might not be routinely available, or at least available in a timely manner for your patient. CT scan is an alternative to MRI. It can also be used to assess the vascular supply if you do an arterial runoff phase. And so it might be used as a first line test, and you can follow up with an MRI if there's uncertainty. Bone scan or nuclear medicine scans can be very sensitive for osteomyelitis, equivalent to MRI, but very limited otherwise. The last thing I'll say is imaging can be very helpful to diagnose some of these complications, but is not the best test to monitor them moving forward. Often imaging characteristics or findings will evolve or even worsen, even when there's appropriate treatment or cure of the infection. And this can also be a challenge in patients who have adequately treated infections, who maybe have a relapse down the road, where the imaging might still show persistent changes related to the prior infection. From this, we'll be able to provide our impression and recommendations, in which we characterize the infection, provide some advice on antimicrobial therapy, which often will represent a transition to oral therapy, which can be effective even when used for the majority of the course. We'll recommend any additional evaluation if necessary. Also, if there's any additional consultations that would be of benefit, either to surgical colleagues, to wound care, even some settings you'll consider nutritional support with diabetes education, dietitian, and anyone who might be able to assist with pressure offloading to allow for better wound healing. And lastly, we'll offer some advice or at least sense of prognostication for the wound or the limb. So an example summary could be, this is a 65-year-old male with longstanding type 2 diabetes, prior diabetes-related foot infection, and peripheral arterial disease, presenting with a plantar foot ulcer underlying the first MTP joint. The ulcer is deep with purulent discharge and probes to bone. He is systemically well but has elevated inflammatory markers. Plain film suggests underlying osteomyelitis. So my impression is that this is a diabetes-related foot infection with likely contiguous osteomyelitis and underlying arterial compromise. And then from this, we provide our recommendations. So again, I'll leave up the key points that summarize our assessment of patients with diabetes-related foot infections, but also leave you with a few additional points. As I mentioned, each case and each patient is unique. And it's important to recognize that even with our best care and optimal management, things might not go as we'd hoped, and you can still see patients with complications such as amputation or even worse. When we are managing patients with DFI, it's important not just to consider our empiric therapy, but also to tailor antibiotics based on culture results and clinical response. And as mentioned, ideally transition to oral antibiotics for the majority of the course where it can be safe and effective. The last thing is something I've mentioned in some of my other talks. It's very important and valuable to follow our patients long term. One, to offer ongoing advice and assessment of their course, but also for our own learning to see the impact and outcomes of the decisions that we make for our patients. Now, there are many excellent reviews of varying depths and lengths that are out there. I'm just giving you two examples. The first is a review of the evaluation and management of diabetes-related foot infections published in the CID. The next is a more general and superficial review of the types of things we would consider when we're assessing an individual with diabetes-related foot infections. So that's all for now. I'm Dr. Paul Bunce, and I want to thank you for watching. Please share any feedback you have on this session or FirstcallID as a whole. And if you find this helpful, please tell a friend. Take care.